Hello, everyone, and welcome back to class. This week, we're looking at randomized controlled trials. And again, the purpose of exploring these different study designs in this first course, some of these may be review, but it's important for us to think about the strengths and weaknesses of each design, of these common designs that may show up in your searches and may be included in your systematic review or within your scoping review. Now, randomized controlled trials, when we look at the hierarchy of evidence, they're right up there at the top. Right below systematic reviews, again, primarily consisting of a review of all the randomized controlled trials on a topic. Sometimes they may include other designs, but again, typically they're all RCTs. Now, if you're looking at a particular topic that is primarily supported by randomized controlled trials, then I would encourage you to do a systematic review. If your topic idea is not as well developed, then maybe you would want to lean towards the scoping review. Now, utilizing an experimental design, the purpose is to rule out rival hypotheses as possible explanations for the observed response through the researcher's manipulation and control of variables and measurements. This week, we're going to be looking at the true experimental or randomized clinical trial. Not presented this week, but we will discuss them next week, are the single subject designs and the quasi-experimental designs. Three essential features. There is the random assignment. Each subject has a chance of being assigned to the experimental or to the control group. The advantage is the equal distribution of known and unknown variables. Of course, there is the control group. Sometimes the control group is a true placebo. Sometimes it is the current standard of practice, because it could be unethical to give no treatment. Third, the researcher has control of independent variables, the independent variable again being the variable that you manipulate or control. Two types that we're going to look at here, the pre-test, post-test group design and the post-test group only design. The pre-test, post-test is the strongest design. Here's a way to visualize this. There is random assignment from your sample. That random assignment hopefully creates equivalency at baseline. The intervention occurs, and then you do post-test measurements. A post-test only control group design looks like this. The sample is randomly assigned to one or the other group. Intervention occurs, and then post-test measurements are occurring at the end. You don't know what they were like at baseline, you just get a sense of what they are like after the intervention. So I think it's pretty easy to think about the pre-test, post-test design. I think we're pretty familiar with that. We'll see examples here. But what about the post-test only? So I took this one from one of my research methods textbooks, and a study was designed to test the hypothesis that high-risk patients undergoing elective hip and knee arthroplasty would incur less total cost and a shorter length of stay if inpatient rehabilitation began on postoperative day 3 rather than day 7. 86 patients who were older than 70 years were randomly assigned to begin rehab on day 3 or day 7. The main outcome measures were total length of stay and cost from ortho and rehab admission. I doubt that many of you will find post-test only examples. It's possible. Just wanted to highlight it. but again, it's probably not that common of a thing that you're going to find. Looking at the features of a randomized controlled trial, you have your sample, shown here by the box with the label patients. Random assignment occurs, moving individuals into a treatment and control group, and then at follow-up, there's a comparison of results. Now, it's important to highlight random sampling versus random assignment. As you read an article, it may say one or both. Random sampling should mean that from a population, a sample was created. And then from that sample, random assignment occurred, moving people to a treatment group or a control group. Many of our clinical papers where people go to a medical office, to a physical therapy office, something like that, they may not have the random sampling. What they may have is a population, a sample that comes to them, and then there is randomization from there. So just being aware of the two different randomization terms. You probably won't see them both listed in a paper. Again, just another way to visualize random assignment from the sample that was created. Again, random sampling would be taking or creating a sample from the population at large. A couple other randomization processes. Oftentimes there is a kind of a completely randomized approach. This could be viewed as a completely randomized approach. Block randomization is a little bit different than that, where in block randomization, you have units or blocks that are created based upon known or suspected variations. And it helps to evenly distribute those throughout the sample, or excuse me, probably sample is not the best way to say that, throughout the randomization process as you create your intervention and control groups. The whole goal is to make sure that both groups are similar at baseline, that no dissimilarity occurs that could confound your results later. There's another called stratified random sampling. This involves identifying relevant population characteristics and partitioning members of a population into homogeneous, non-overlapping subsets based on these characteristics. Sounds a lot like block randomization. Both blocked and stratified randomization are strategies to balance groups in a study, but they have a slightly different focus. Block randomization primarily ensures roughly equal group sizes, while stratified randomization aims to balance groups based on important characteristics like age. That's what we see in the example on the left. Could be done based upon something like disease severity. And sometimes researchers will even utilize both techniques by stratifying within blocks. Here's an example of a stratified sample where you're looking at undergraduates in a collegiate setting. You want 100 people. The accessible population is 1,000, but you want to have a proportional sample from each group. You wouldn't want to try to sample from the 1,000 and potentially get more of one, less of the other. And so the stratification that occurs here is to get 30 from the freshmen and the sophomores, and 20 from the juniors and seniors in order to have that be proportional to reality. Cluster randomization, this occurs when the randomization of individual participants is not practical. And so in this situation, instead of having an individual randomized to a group, you might randomize a clinic or a hospital setting. You may do it based upon geographic region. And so intervention cluster at the top there, maybe that's all of the Providence systems, and the control cluster then is all of the legacy systems. There is non-probability sampling, and non-probability sampling then makes things not experimental in nature. We lose the randomization. I only highlight this right now because as you read things, if you read something that talks about convenience sampling, quota sampling, snowball sampling, etc., those are different strategies to come up with a population, to come up with groups, but it's non-random in nature. And as a result, there may be an inability to generalize the findings to a wider population because some segments of the population may be disproportionately represented. Recommend that generation of random sequences should be done by some independent personnel, usually a statistician, who's not going to be involved in the conduct of the randomized controlled trial. All right, looking at allocation concealment. This is one of the key components of a randomized controlled trial. That is allocation concealment. This means that neither the frontline care providers, investigators, or participants are aware of whether the next eligible participant will be receiving the treatment or control intervention. This should be masked until the time when participants are ready to receive the intervention. It's really interesting that a lot of our things that we do may not be able to completely conceal allocation. If you're doing a drug-related study, this becomes pretty easy to do, right? If there is a white treatment pill and a white placebo pill, and they're of the same size, etc., the frontline provider or the investigators may not have any appreciation as to what treatment that individual then is receiving, and then the individual doesn't know either. It would be then the statistician or other investigators who are not part of the application or the conduct of the study that would know. But there's lots of times which it becomes impossible to have that level of concealment. Now, a randomized controlled trial does help to reduce some common types of bias. Bias is defined as any tendency which prevents unprejudiced consideration of a question. Blinding oftentimes will say in the title of the article. If not, you'll read it in the abstract or you'll understand it from the methodology. With blinding, the participants can be blinded, not knowing what treatment they're receiving. Both investigators and participants can be blinded, helping to reduce potentially a form of bias. But it can be difficult. Single versus double hamstring tendon graft in ACL reconstruction in the pediatric patient, a single-blind randomized controlled trial study protocol. Here, it would be very difficult. It would be impossible to blind the orthopedic surgeon as to which tendon graft was being used. Double blinding can be performed effectively with drug types of studies. Blinding then is not always possible. This was from a study that we did using blood flow restriction training, and we weren't blinded because we were applying the blood flow restriction training to the subjects. And it's possible then that subjects weren't blinded because they were all within the same cohort of students, and so people would be able to know if they were receiving the blood flow restriction intervention or not. Now, a randomized controlled trial can be conducted at a single site or at multiple sites. A randomized controlled trial conducted based upon a single protocol, but at more than one site. That's known as a multi-center trial. And including several sites has the advantage of reaching the required sample size within a shorter time and may also improve then the generalizability of findings. Primary and secondary outcomes should be collected by independent observers who are unaware of the allocation and treatment arms of participants. You should use objective measures to help avoid personal bias. This is important, especially if the intervention cannot be masked. For example, surgical scars for surgery versus a conservative care group. Outcomes should be collected in all participants, and a high attrition rate threatens the validity. Sample size. That's the number of participants included in a study, represented by N. And ideally, somebody would report that they did an a priori sample size estimation to determine how many subjects needed to be recruited in order to have the study meet statistical significance. There's other things that might be reported in the paper, such as an effect size. This is how meaningful the relationship between variables or the difference between groups was. And a common measure of effect size is the Cohen's d. So the p-value tells us if something was statistically significant, in other words, it worked, but the effect size tells us how much it worked. Cohen suggested that a effect size of 0.2 was considered small, 0.5 is a medium effect size, 0.8 is a large effect size. This means that if the difference between two groups, the means is less than 0.2 standard deviations, the difference is negligible, even if it is statistically significant. It becomes more meaningful as that effect size increases. Now, the inclusion of too few patients in a study increases the risk that a significant treatment benefit will not be shown, even if an effect size exists. This is why it is valuable for researchers to report the sample size estimation ahead of time. Up at the top here is reality, but over the side here is the study findings. The study findings, this is where the researchers are living. They conduct the study, and their whole goal is to get findings, and those findings are either going to be positive or negative. But now errors can occur, and so What if the study reported negative findings or that there was no statistically significant findings? However, in reality, had there been an appropriate sample size, they would have found something. So this is a false negative. So as you read a paper, do the authors report an a priori sample size calculation? Or do the authors base their sample size on previously reported research? That may be an acceptable way of doing things. If Johnson et al. Reported that 100 subjects was appropriate, then maybe Smith et al. Might model that same sample size. So looking at our 2x2 table here, the power of a study is calculated ahead of time, as well as the alpha, and those are plugged in. We typically put a power 1 minus beta. Beta is set typically at 0.80 and alpha at 0.05. And if you have a large enough sample size and you get a positive study finding, then you most likely have a true positive. But if you didn't have an adequate sample size, you're going to potentially have a type 1 error. Study was positive, but in reality it was negative. Vice versa, if you have a negative study finding, but it was actually positive, that would be considered a type 2 error. Here's a way to visualize a type 1 error and a type 2 error. A type 1 error is a false positive. A type 2 error is a false negative. Now, as you look in papers, there will either be the presentation of a null hypothesis or an alternate hypothesis. Probably 99% of the time, authors will present the alternate hypothesis. And that's the hypothesis we're trying to prove, which then oops, sorry about that. I was thought I had paused things here, and because my family member was talking to me, but I guess I had not. So getting back here to the alternate hypothesis. But the alternate hypothesis, we are again trying to prove that, and if it's accepted, that means there's sufficient evidence that we're able to reject the null hypothesis. The null hypothesis is rarely, if ever, presented. And it's a statement or claim being made that we're trying to disprove, that there's no difference between groups. You'll know if it's the null hypothesis if somebody says, we don't believe that there will be differences between groups. Usually somebody will say, we believe that there will be a significant difference between the experimental group and the control group. Type 1 error means rejecting the null hypothesis when it is actually true. It means concluding that the results are statistically significant when in reality that finding came about by chance. The risk of committing this error is the significance level you chose. P-value again typically set at 0.05, which means that your results only have a 5% chance of occurring if the null is actually true. Type 2 error means not rejecting the null when it's actually false. So you failed to conclude that there was an effect when there actually was. This means that your study may not have had enough statistical power. Power is the extent to which the test can correctly detect a real effect when there is one. Power is usually considered acceptable at 80%. The power one selects is used to calculate the sample size. Is a type 1 or type 2 error worse? Well, both could be bad, and it depends upon your example. Type 1 example. Based upon the incorrect conclusion that the new drug intervention is effective, over 1 million patients are prescribed the medication despite risks of severe side effects and inadequate research on the outcomes. The consequences of this type 1 error also mean that other treatment options are rejected in favor of the intervention. Looking at a type 2 example. If a type 2 error is made, the drug intervention is considered ineffective when it can actually improve symptoms of the disease. This means that a medication with important clinical significance doesn't reach a large number of patients who could tangibly benefit from it. All right, now, if you're looking at a drug-related study, they might have particular trials to it. And so there is a process that goes through looking at smaller samples to assess safety, then next larger samples, safety and dosing, and then finally the largest samples are going to be looking at safety and efficacy, and finally post-approval surveillance. The answer provided by randomized controlled trials is applicable to the patient population similar to that used in the trial. Extrapolating it to other patients is not strictly valid. To do so, inclusion criteria should be as wide as possible. So this is an important discussion topic. As you've developed your PICO, if your P includes all adults, well, that's one thing. But if your P is focusing on young adults 18 to 25 and of the biologic sex female, well, then that's going to really limit the generalizability to older biologic sex females or to even males. An interim analysis, this is something done by an independent statistician, and this is done potentially throughout the process, but it's done to compare the differences between groups and to see if there is a clear advantage in the intervention. Because if you're seeing something that is profoundly impactful, positively affecting the intervention group, then it would be unethical to continue to give the control group the placebo when the intervention is clearly the superior alternative. Vice versa, a discontinuation may be advisable too if the intervention is not having a positive effect upon individuals. Now, some ethical considerations and safety concerns. Is it ethical to do a randomized controlled trial if there's already a good treatment? And potentially, yes, it could be. But this is where the researchers would need to have something get approved by the institutional review board and to show that what they want to do could address side effects or maybe improve mortality rates or something like that. Looking at the treatment, is it safe? Again, the institutional review board is going to be looking to see if that treatment suggestion, if that treatment intervention, does it potentially outweigh any harms associated with it? So all studies need an IRB review, and you'll see that within the methods section. It'll list which IRB approved it. Okay, here's your homework assignment. Choose a randomized controlled trial of your choice. Read the article and review it using the CEBM RCT Therapy Study Critical Appraisal tool. I've uploaded that into this week's module. Submit the following by midnight: a PDF of the article and highlight sections for categories 1 through 3. Then have a Word document describing sections 1 through 3, providing your critique. Also describe the outcomes of the study. Was the finding statistically significant? If so, was an effect size reported? And what was the effect size? Looking back at that Cohen's d information. Finally, would this study help you to make a clinical decision? And this is what you're looking for online. in this week's module.